My name is Ben Campbell. I'm a certified registered nurse anesthetist. I've been a CRNA for 34 years. I have experience in all types of administration of anesthetics, whether it's in medical centers, rural hospitals, freestanding surgical centers, doctor's offices. I have 28 years experience in the U.S. Military Reserve. I'm familiar with how anesthesia is provided in medical centers, VAs, combat support hospitals, forward surgical teams, combat support hospitals. I'm intimately familiar with how anesthesia is provided in all of those settings and the interactions between the anesthesia providers and the surgeons also. Today I'm going to be honest and forthcoming. I've not come before you wearing a white lab coat trying to intimidate you. I'm not wearing a name badge of my facility against their policies. I've not sent you letters on my hospital's letterhead making you think that my opinion is theirs and that I'm speaking for them. Those have all been done in front of this committee before, and that's not what I'm here today to do. As far as background, CRNAs have been giving anesthesia for 150 years in this country. We're not something new. We're not a new provider. CRNAs were the first organized nurses to provide anesthesia, to teach anesthesia in nursing schools. CRNAs were initially the ones that were teaching MDs how to give anesthesia. Initially, physicians didn't care about anesthesia. It was just considered a necessary adjunct in order to perform surgery. It wasn't considered the practice of medicine. Physicians back then wanted to treat patients, and anesthesia wasn't considered treating patients. Anesthesia was not and is not the sole purview of the practice of medicine. CRNAs are not just nurses, as our opponents like to call us in the news and the nurspapers. If you will allow the analogy to the military, which I am, nurses are not the GI that just graduated from basic training and was sent to the field. Nurses are the SEAL Team 6 of nursing. We are practicing at the top of our profession, the top of our license. We're a select few that have been picked for the most rigorous training in nursing. We've had advanced degrees, we have graduate degrees, master's degrees. We're the first nursing profession to require a master's degree. In a few years, every CRNA graduate will have a doctoral degree. We're the cream of the crop. We know what we're doing. We've been taking care of patients for many years. We have vast experience. SB 184 is not an independent practice bill. It is not a prescriptive authority bill. It is not a collaborative agreement bill. The reason that we wish to change the language in this bill is because it's a barrier to our practice, it's a barrier to the hospitals that want to hire us, and it's a barrier to the patients that we try to serve in our communities. So let me explain a little bit about what's going on. So we want to change from supervision to collaboration. What is supervision? If you'll notice, supervision is not defined in the law. It was initially not defined on purpose because it wanted to allow the maximum flexibility without being restrictive. Supervision connotates the direction of one person over another. However, this has been perverted to assume a legal responsibility by physician anesthesiologists. As our physician anesthesiologist colleagues are fond of telling surgeons, that they carry increased liability when working with CRNAs. This is a lie. In the early days, the legal doctrine of surgeons working in the hospital was captain of the ship. That is no longer the rule. The surgeon is no longer solely responsible for every person in the operating room. Medicine has evolved, anesthesia practice has evolved, and each person is now an expert in their own field, carrying their own liability and their own responsibilities. This has been borne out in multiple court rulings. supervision of CRNAs no longer represents the reality of modern practice in the field of anesthesia. Supervision connotates oversight and direction, and this is no longer applicable in regards to the surgeon working with a CRNA. So what is coordination? Some of you have said, I can't understand what you mean by coordination. Coordination doesn't mean anything other than what the definition of coordination is. So let's be clear. Coordination means no more than the coordination of elements of a complex activity to enable them to work together effectively, or a cooperative effort resulting in an effective relationship. If you will, a surgical team. This most accurately reflects how modern surgical procedures are accomplished and how CRNAs work with surgeons. We are not trying to be doctors. I've heard some of you say, if you want to be a doctor, go to medical school. If I wanted to be a doctor, I would have gone to medical school. I wanted to give anesthesia, so I went to nursing school. We're not trying to be doctors, we're trying to be CRNAs. That's what we do. What CRNAs do does not fit the definition of the practice of medicine. In actuality, it's the physician anesthesiologists who are trying to co-opt the traditional role of CRNAs. My response is, if the doctors want to give anesthesia, they should have gone to nursing school. So what is the practice of medicine? The practice of medicine is defined as a profession devoted to preventing, alleviating, or curing disease and injuries. Nowhere in that can you generate the practice of medicine or the practice of anesthesia. So, why are physicians and anesthesiologists so defensive, aggressive, and continue to try controlling a field that doesn't even follow the basic tenets of the practice of medicine? Why are doctors even involved in anesthesia care today? Why are physician anesthesiologists trying to control anesthesia practice? Why is the stated goal of the American American Society of Anesthesiologists the elimination of all CRNAs? Why are physician anesthesiologists trying to control what has traditionally been the role of CRNAs? And today, why are CRNAs being threatened if they come before you today and try and testify? CRNAs are being threatened. So, why have PAs attempted to sue CRNAs claiming they were practicing medicine? Why are they trying to invent a new anesthesia provider called an anesthesiologist assistant that can in no way work with a surgeon or a dentist as a CRNA can today? These anesthesiologist assistants are subservient to physician anesthesiologists only. They can't even work in an environment where CRNAs can work now. Does this sound like a hostile takeover, an attempt to dominate a market? It should. So, in this market, in addition to our education and our board certification, CRNAs cannot even practice if they are not board certified. But somehow there's an exemption for physician anesthesiologists who can continue to practice even though they have failed their boards. That's not an option for CRNAs. In a moment, I'm going to tell you the dirty little secret everyone in the operating rooms of America know, but few outside those doors want to speak about. But first, let me dispel some of the myths and the slanders and misleading comments being made in the newspaper and on TV about my profession. Safety. You've all been told all of these studies about safety. There's this side and that side and statistics. Just forget all of that. Let's get down to reality and let's talk about what's really going on. What entity controls markets based on risk assessment? What industry makes huge amounts of money by avoiding risk? Insurance companies. If there was any question that CRNAs were not a safe provider, we could not get malpractice insurance. The actuaries of insurance companies have looked at our practice nationwide and determined there is no increased risk whether a CRNA is working with or without a physician, supervised or unsupervised, working with or without a physician anesthesiologist. If we don't have malpractice insurance, we cannot practice. My malpractice insurance during my career has gone down 39%. If I was not a safe provider, they would not lower my premiums. I have the same exact malpractice coverage as a physician anesthesiologist. My rates and coverage are no different. So if we're such a threat to public safety, why don't malpractice insurance companies continue to insure us? This is not just a physician anesthesiologist and a CRNA working together, or a CRNA working with a surgeon. It's the same nationwide. These actuaries cannot find any difference in the quality of care or safety. So despite what the studies say, it's beyond belief that someone would question our safety. Even Centers for Medicare and Medicaid Services have said they do not care if CRNAs are supervised or not. This is the federal government. If you don't want supervision restrictions in your state, just tell us. We don't care. So when a physician anesthesiologist comes before you and says safety is a factor, are they to be believed over CMS? Or are they to be believed over the 40 other states in the United States that have no supervision of CRNAs? It just doesn't hold water. As you now should know, this committee have been told lies in testimony before you in the past. You've been told patients are at increased risk when we work unsupervised. That was a lie. You've been told patients die when we work unsupervised. That's also another lie. You've been told that Arkansas Heart Hospital had patients die because there was not a physician anesthesiologist available. That was a lie. Dr. Kimbrough wrote you that letter. She is now being investigated by the Medical Society for her part in that letter. Dr. Dilly testified before you that we were only trained to follow orders from a physician anesthesiologist. That is a lie. This is despicable behavior coming from a group of people who call themselves professionals. At many hospitals that have physician anesthesiologists and CRNAs at the same group, at the end of the day, at night, holidays and weekends, who is there in the operating room finishing the day? Who's coming back during emergencies and taking care of the patients that need our help? In most cases, the physician anesthesiologists go home and the CRNAs are left to be on call and finish the day, take care of emergencies that come in, take care of women that come in labor that need an epidural. The physician anesthesiologist is most often at home.
Excuse me,